This is Dr. Shweta Patel. I am coming to you actually not so live from Winter Garden, but in North Carolina. I am still visiting family and having a blast. For all of my Hindu followers, belated Happy Holi, and I hope you had a wonderful Festival of Colors over the weekend. I know I sure did. So today's topic, to make sure that we get to overall a comprehensive live, because it is a pretty big topic. Today's topic is actually called discussing fibroids. Now, fibroids are a non-cancerous tumor that can happen in the uterus of a woman. And they're actually very common. 1 in 5 women will typically have them. Most women don't even know that they have them. And frankly speaking, if you have a fibroid detected on an ultrasound or on an exam by your physician, nothing really has to be done about that if it was not causing you any symptoms or concerns. A asymptomatic fibroid, or a fibroid you didn't even know about and wasn't even bothering you, is best left alone, because that is not something that has to be addressed. And if we're talking about taking the most minimalist approach, then it would be to just continue to observe it, maybe have another ultrasound done in a couple of months or in a year or so, just to make sure that it hasn't grown dramatically in size. But how a fibroid affects a woman really is dependent on where it's located. So if you were to actually take a look at the picture that I posted earlier this morning, a fibroid can be, the way I describe it in the office is, a fibroid can be, if you imagine a house with the roof and the sidewalls and the floor, a fibroid can be on the roof outside and has no contact with the inside of the house. And that's what we call subserosal or serosal fibroids. And a fibroid could be actually dangling from the inside of the house, like a ceiling fan or a chandelier, with no connection to the outside. And that's what we call a submucosal or a mucosal fibroid. And then there can be a fibroid that's like built into the wall, like windows, where it's kind of going a little bit of this way, a little bit of that way. And those are what we call transmural or fibroids, meaning they're kind of like in both worlds. And then after knowing where they're located, the next big thing to ask or know about is how big they are, because size does cause the majority of the symptoms. And the next big symptom outside of size related pressure or pelvic pain or cramping is how much bleeding it can cause. So fibroids are the same kind of tissue that is made up inside the uterus. The uterus is a muscle, and it has 3 layers, but the primary layer is a muscle. That's what allows it to cramp and cause a woman to have her menstrual cycle. It's also what causes it to cramp and allow a woman to have a baby. So that muscle can then start forming little aberrant knots, which is what a fibroid is. But outside of that, it's typically not likely to become something that goes other places or malignant metastatic. Now, the reason why they can become very big is because they are getting the same exposure to blood that the uterus is at the time a woman is menstruating and at the time that the woman's hormones are going up and down when she's ovulating. So they are stimulated by the uterus and the ovaries growth. The ovary actually will stimulate the ovary will actually stimulate the uterus with hormones, and that stimulation to build up a lining and shed a lining actually accidentally is also stimulating the same process in the fibroid. So a fibroid can get very big based on the fact that a woman is in her perimenopause age, as in she is still ovulating, and it can also be very big because of its location. Location being, if it's in the middle of the wall, that's where most of the blood supply is, and so it gets a little bit more juicy and big, as opposed to if it was on the inside or on the outside. That doesn't mean the inside ones and the outside ones can't get big. I can tell you from personal experience that I've seen fibroids of all shapes, sizes, in all different locations. But which ones cause the most bleeding are location dependent. So if you have a fibroid that is causing bleeding, it's usually the one that's dangling from the inside like a ceiling fan, and that doesn't have any communication to the outside of the uterus. The fibroids that are on the roof of the house, like a chimney or a satellite dish, they are not causing bleeding. Unless some of it is also somehow exposing itself through the wall. But for all intents and purposes, when we think of a satellite dish, if there's a problem with the satellite dish on the roof, we're not fixing it from inside the house. We're fixing it from outside the house on the roof. And that's the same thing with fibroids that are on the outside of the uterus. They're not usually addressed from the inside of the uterus, and they usually don't actually cause any symptoms on the inside of the uterus. And the opposite is also true. Fibroids that are dangling from the inside are typically causing not necessarily pain or pressure. They're primarily known for how much bleeding they can cause. And addressing them is usually best, depending on the size again still, done from the inside of the uterus as opposed to coming out and in. So how do we actually identify fibroids and then what do we do next? Typically a fibroid is what I call an incidentaloma, meaning it was incidentally diagnosed on an ultrasound done for another reason. Most times women don't even know they have them. Then again, the opposite is also true, where if you are having a pelvic exam and there is a large mass on your exam, getting an ultrasound can reveal that that is maybe a external or a serosal fibroid. And if you're having heavy symptoms of bleeding or symptoms of heavy bleeding and lots of cramping and pain on your period, then the ultrasound may reveal that the fibroid is located on the inside. So the number one way of detection outside of a physical exam is getting a pelvic ultrasound, which you can have your doctor order for you. And then other ways, of course, is like MRI, CAT scan, but typically our preferred modality, ultrasound. And then how do we treat them? So remember the part where I was like, the ovary is talking to the uterus, getting it prepped for its monthly routine, and it's accidentally also giving the same message to these fibroids. So if we stop the ovary's communication with the uterus, we can actually also stop the ovary's communication with the fibroid. So the number one way that we typically go about doing treatment for heavy bleeding due to fibroids or large fibroids is by starting you on some form of hormonal suppression, also known as birth control. And I typically recommend the pill, the patch, NuvaRing, the subcutaneous implant, or depending again on the location, sometimes you're also able to utilize progesterone-only options. And the other very first place to start is using NSAIDs, non-steroidal anti-inflammatory drugs. This is because they can actually reduce the overall bleeding and cause the symptoms of pain to be improved related to fibroids. So ibuprofen and birth control are the mainstays of treating fibroids. But if you have a very large fibroid and you're trying to treat it with hormonal suppression, you may not see as dramatic of an effect in making it smaller. You probably will see a great effect in making it not bleed because you're not letting the bleeding start. And once the bleeding isn't triggered, the deluge doesn't happen. But if it's a matter of size, if you're having pain with sex or having pain with exercise because you have a ginormous fibroid and it's actually protruding out into the back of the uterus and pressing on your colon or pressing on your bladder, that is going to probably behoove some more robust treatment, and starting with birth control is always a great place, but I wouldn't spend too much time on that because it's not likely to have as dramatic of an improvement as other options. Other options are what I typically like to refer to as selective estrogen receptor modulators or gonadotropin agonists, excuse me. That's all mumbo jumbo for we've got bigger guns than birth control. And they're available both in oral form and injectable forms. The injectable form is usually once a month or a 3-month dose, and the oral form is usually once a day, just like a birth control. But it's not a birth control pill. We're not using actual hormones to make your ovary stop ovulating. We're actually using medication that looks similar to estrogen, and it plays musical chairs with estrogen receptors and estrogen so that it blocks them, prevents estrogen from actually locking on or docking into its receptor, and so the ovary doesn't actually get to give the message it wants to give to the uterus. The only concerns with that route of treatment is usually that it can cause some pretty significant side effects. Whenever we're altering your hormones or manipulating them, there is always a small chance that you can experience symptoms like hot flashes, emotional changes, breakthrough bleeding, possible weight gain. Often patients will complain of like migraine headaches. And these are also recommendations for a standard situation. If you have any history or background of being prone to blood clots or have multiple medical conditions like high blood pressure or a history of blood clots, that's a whole different conversation. And I think it would be best to have more of an individual discussion one-on-one. But these comments are specifically for the actual general situation of any woman who is healthy otherwise, has no other pertinent medical history. And the next option up would be if you wanted to consider having something done that was surgical. So the simplest options would be having either transuterine surgery, where we actually go inside and destroy the fibroid in various different ways and shapes. We can use ultrasound technique. We can use direct destruction using cautery or ablation devices. And we can actually just shave down the fibroid in multiple small bits and pieces. That is a same-day surgery, again, typically depending on how large the fibroid is. And if it is successful, then you are able to kind of get back to doing whatever you're doing as soon as possible with very little downtime. This is something I would recommend, especially if the fibroid is on the inside of the uterus dangling down, it's causing heavy bleeding, and you're in your conceptive years where you would like to have children or would still like to have the ability to have children. If you are done with childbearing, this is going to sound a little bit extreme, but our uterus really doesn't have a purpose outside of childbearing. So if you're done with childbearing, then there are less minimally invasive options than a hysterectomy when you're treating fibroids. But the only way to actually remove the potential of a fibroid ever happening again, not just remove the fibroid itself, is to have a hysterectomy. So that's the way down the line, like, penultimate extreme option of, hey, let's just take the uterus out. Probably better if it's a very large fibroid or a large uterus with multiple fibroids, where trying to pluck them out individually will render your uterus kind of like a rag doll. If you have the plan for wanting to still conceive, and particularly if you have maybe just one or two or a few large fibroids, not multiple small ones that will kind of make it difficult to, cut and piecemeal back together your uterus, then it's the best idea is to actually have a discussion about a myomectomy, which is basically a fibroidectomy, and that can be done both laparoscopically and it can be done with an open procedure. And again, each person is different. One-on-one conversation with your doctor as a preoperative visit is probably advised, but that is another option to consider, particularly in women who are wanting to preserve their ability to conceive. One more option I didn't discuss, and then I'm going to wrap this up, is uterine embolization. And that's basically where, if you were to think of the blood vessels that go to the uterus like highways, then we're going to take the main highway down to its exit all the way to the one street that's supplying the fibroid. And we're going to block that street off, basically preventing any traffic from going into that home. So in other words, we are using our large blood vessels that supply the uterus to trace down specifically which blood vessel goes and feeds into the fibroid itself. And then we occlude it with little beads so that the fibroid is essentially tourniqueted off from its main supply and it gradually becomes smaller. That is done by interventional radiologists, actually not particularly by gynecologists, but we do work together so that if that is something you're wanting to do, we can refer you. So to recap, fibroids, not a big deal. You don't have to actually do anything about them just because you have them. That's like saying I have to remove my appendix because it's in there. No, we don't. We don't routinely have surgery or go looking to see if something's going on with our appendix. However, if you have symptoms, heavy bleeding, pain, lots of pressure or pain during sex, or feeling like bulk symptoms like, whoa, I know I'm not, in perfect shape, but my belly just feels way larger than it should, I would recommend being evaluated. And if you do have a fibroid detected that's kind of coincides with your symptoms, then the options would be starting with the simplest, non-steroidal anti-inflammatories, birth control pills, considering things like selective estrogen receptor modulators, which is oral form, also known as Orilissa. No conflicts of recommending that. Or you can consider an injectable form, which is known as Depaluperon. And if you are interested in having more definitive surgery rather than a gradual process, you can consider having a myomectomy, which is where we individually remove the fibroids. It can be done both from within the uterus or outside of the uterus, depending on where the fibroids are. And that's particularly something I would recommend for patients who want to preserve their ability to conceive. If you are done with childbearing, if you are approaching menopause and this is causing you some dramatic symptoms, or if you've tried some of the other things and they have not worked, then the next and final step would be to consider having a hysterectomy. All right, everyone, thank you so much for listening. And if you have any questions, please send me a message and I will be happy to answer them. Or you're also welcome to write a message on the my page's wall, and I will definitely answer them. And that way we can kind of share our questions openly, and my answering one person's question might answer somebody else's. And then lastly, an update on GAYA. Love all the support. Thank you so much. We're working on our website. We're working on getting credentialed with insurances, and I am very close to releasing the telehealth app that I would like to use. And then of course I'm going to start with free telehealth services as soon as I am able to. Stay tuned for more. Don't forget to like and follow and share, and all the best, and have a wonderful week. And we'll see you back actually tomorrow, since we're a little bit off on our schedule. Have a good day, everyone.